Thank you, Sophia. And as we are in the middle of transitioning, I will begin to introduce to you my colleagues on the panel. First, we will hear from Dr. Tim Cunningham, the Corporate Director of Patient and Family-Centered Care at Emory Healthcare. Next are Dr. Bernadette Melnick, who is the Vice President for Health Promotion and the University Chief Wellness Officer and Dean and Professor at the College of Nursing at The Ohio State University. And third, we will hear from Dr. Jason Wolf, who is President and CEO of the Beryl Institute. Thank you. So,
we'll get him, Tim.
Thank you all so much. As we transition into the high-tech, thank you, Adrian, for blanking the screen, by the way. Let's get away from tech for a hot second. We're moving into high touch right now, people, okay? So I'm going to ask you, and this might feel uncomfortable, but let's roll with this. I'm going to ask you to gently take your tech and put it down. If you're really into taking a big risk, put it away. All right? And then what I'd like you to do is pay attention to how long it takes before you go back to the high touch and you touch your tech. All right? Just notice it. No right or wrong answers. I'm not going to judge you too harshly when you start tweeting and texting. I'll judge you less harshly if you tweet at me at Tim Cunningham RN. Feel free to do that. But just take in what that experience feels like. In 1991, writer and activist Audre Lorde was tapped the Poet Laureate of New York. A decade prior, she published the words, "Taking care of myself is not self-indulgence. It's a form of self-preservation." And that is an act of what? You all know this quote. That is an act of political warfare. Let's think about that. An African-American activist female writer talking about this idea that to do her best work, to be her best self, to advocate the best way that she knew how, she needed to do things every day to preserve herself so she could literally get back out of bed and produce brilliant work in a country that already didn't like her simply because of the color of her skin and also of her gender. Self-preservation. I'm going to talk about self-care in a little bit, and as I talk about it, I'd like you to maybe think about, is this more of self-preservation as we go into that? I'd also like you to think about nurses. I was a professional clown for about a decade. Doors are back here if anyone is a coulrophobe. I totally get it if you need to step out. I'm not going to do anything clowny, I promise. And then working in humanitarian settings around the world, I was inspired to learn more about why families and countries just a couple of hours flight away from New York City were dying because of lack of access. So I went back to school and I studied nursing. I've been a clinical emergency nurse for about a decade, went back to school because I like going to school, and studied public health and resilience. Having worked clinically, and having learned in nursing school very quickly the adage that nurses like to do what? Play cards, yeah, that's the new one, right? Thank you. And when they take a break from playing cards, we like to eat our own. I was taught that over and over and over again a decade ago. And fortunately, I think that has gotten better in nursing culture. And at the same time, we have a lot of work to do. And when I think about health systems, and I think about self-preservation, I also would argue that we are working in health systems in the US that are not actually designed to care for us. Quite in fact, nurses are frequently devoured by the systems in which they work in. Quite often, as we are being devoured, we take that out on our patients. And we mistreat our patients, and we don't provide the equitable care that we are striving towards. And we also end up eating our own selves. I don't know if Audre Lorde thought about nurses when she wrote those words, but I think there are a lot of commonalities. So what can we do to provide the highest quality of care while caring for ourselves. I'm in an interesting position right now. I'm transitioning out of my past job as the director of the Compassionate Care Initiative at the University of Virginia, which informs much of my presentation today. And I'm moving into a new position focusing on patient and family-centered care for Emory Healthcare, which I think all of this work really comes together in many ways that are profound for patients and families, but they're the soft stuff. And we all know that the soft stuff is often the most challenging stuff to measure. Adrian, do you mind turning on the screen for me? So what I'd like to share to you today, and for the panel, is a potential model in how we can think about building up the challenging staircase towards higher quality care, looking at improving certain quality outcomes, while ultimately, first and foremost, ensuring that we as nurses, as physicians, as social workers, as chaplains, are caring for ourselves. I used to say it begins with self-care. And all too often when I was doing my research at UVA, people would come to me and say, A, it's selfish, one, and two, I had a nurse come up to me and say, I just don't have time for self-care. We did a small cross-sectional survey of nurses in our health system about 3 years ago, asking them that question: what do you do for self-care? Those that practice self-care said we do exercise, we engage in prayer and spiritual activities, and we engage with music. We found that our nurses who exercised roughly 6 days a week also scored higher on scales measuring stress, therefore saying I have lower stress in my work because of this exercise. Those that pray and engage with music 7 days a week also scored better scores on the other surveys. But one nurse, and I'm a qualitative researcher, so I really get into that, one nurse came up to me and said, I love this idea of self-care. I love it, but I just don't have time. Does that resonate? I wake up at 5 in the morning, and my kids are asleep, my partner's asleep. I get up and I read the Bible for 15 minutes because I'm a Christian and that is what I do. And then I make lunch for my kids and I pack those lunch bags so when they go to school, they can grab the bags and take them to school. Sorry, I just don't have time for self-care. And I looked at her and I wanted to gently shake her by the shoulders and say, you're doing it. You're already there. What if we heard as nurses first that you're good enough, that you're strong enough, that you're already doing that, and then what if we built from that in designing programs to support self-care and self-preservation among nurses? We can't care for others if we don't care for ourselves. We know the oxygen mask adage, but how about this metaphor? Let's think about the heart. Every time the heart beats, the heart takes freshly oxygenated blood from the lungs, and where does that blood go? Back into the heart, to first feed the cardiac tissue so that the heart is then strong enough to push blood to the tips of our toes and the tops of our head. The heart as an organ feeds itself before it feeds the rest of the body. But what do we do as nurses? I think often quite the opposite. With a self-reflection practice, whatever that is, whatever that looks like for you, I think of the words of Jon Kabat-Zinn, who developed mindful-based stress reduction. He loves to say, there are a million doors into the same room. What's your door? What is your regular practice of self-reflection so that you can, and who's looked at your phone? I see a screen out there. Right? I need to get on, let me check here. You can better pay attention in this world of distractions. I love tech. Tech has saved my life in many ways. I worked as a first frontline responder during the Ebola epidemic in 2014 in Sierra Leone, and tech saved our lives, though we didn't have enough. I love tech, but it's also such a great distraction. Much of the burnout literature does cite new technical advances in leading to feelings of burnout among clinicians, because we just don't know how to handle all this, and we want to focus on our patients. So I think when we think about tech, that's a very important piece to think about. Are we pulling clinicians further away from the people they signed up to care for? We know that mindfulness practice can improve attention. If you look at the work of Amishi Jha from the University of Miami, it's profound what practices can do in honing in attention. And if we're not paying attention, especially as nurses, think of all the things that we're missing. So how do you build that attention? And in building that attention, noticing the connections that you are making with your families, with your friends. I have an anecdote, and then I'm going to share some data as well. My first career, like I said, was a nurse. I worked for an organization called the Big Apple Circus Clown Care Unit. I worked in Boston Children's, Hasbro, and New Haven, and I literally roller skated through the hospital, dressed as a clown, toilet papering rooms, and doing whatever it took to invoke connections with families. And it wasn't always laughter. It was often tears. And not in scary tears, but like, yeah, oh, I haven't seen my child smile in weeks. And every Christmas time, I would get a check in the mail from an anonymous woman living in New York City with a handwritten note, and she said, 2 decades ago, my child was acutely ill, and he spent weeks in an ICU at a hospital in New York City. He was intubated. He had every procedure done to him. We frequently thought he was going to die. And there were clowns in the hospital. And when I first heard about the clowns, I was like, not in my room. No, my kid is dying. I don't want clowns. But the clowns came in. The clowns performed for the child. This was after he was intubated. And he laughed. Kid went home. Kid survived. Kid is still alive today. And for decades afterwards, when the family talked with him about his experience, the first thing that he brought up was, I loved it when the clowns came into my room. Now we know in the literature, what's the number one fear of children in hospitals? Not clowns, that's in America, that's like outside of hospitals. Needles, right? Fear of needles. So usually when you talk with the child, what was your experience like? Or when they come back into the emergency department where I've worked, I don't want a shot. I don't care what you do, I just don't want a shot. But his first thought was remembering this connection and the clowns. How do we measure this stuff? Is the connection. If our nurses are not resilient, if they're not empathetic, if they're not providing compassionate care, and we need to be clear that there is a very clear difference between empathy and compassion. Tanya Singer, the Max Planck Institute, has done some incredible work looking at our empathetic and compassionate responses. When we think of empathy, it's in brief this idea of putting your feet in someone else's shoes, right? I am with you, I recognize your suffering, I feel it. Parts of your brain, according to Tanya Singer's work, actually light up. If you were witnessing someone get injured, that region of your brain lights up similar to the region of the brain of the person who's getting injured. So in some ways, your brain is feeling that person's pain. That's empathy. Tanya has then done compassion training with her subjects, run them back through an fMRI, expose them to another vision, they watched a painful video, painful experience. In a compassionate reaction, regions of the brain light up, but not as significantly compared to where you would feel the pain. But then regions in the prefrontal cortex that also are associated with creativity, with joy, not joy that someone's getting hurt, but joy in I'm a trained professional and I know how to fix this creativity, light up. We often talk about compassion fatigue. I don't think that exists. I think empathy fatigue exists. If we are constantly in someone else's shoes, constantly feeling their pain, of course we're going to burn out. But if this literature on compassion is accurate, and there's a lot behind it, it's pretty interesting to think if we're actually having an authentic, compassionate, creative response, we're fueling ourselves, and we might be able to bounce back better and work another 12-hour shift in the ICU the very next day. So when we think about that, we should really think about the difference. And it's through compassion that we build those connections towards higher quality of care. There was recently a study published in Health Affairs, authors Tofoludi and Stuckler. They looked at 134 hospitals within the NHS system, and they found that hospitals where employees reported a feeling of openness, where they could openly communicate with their colleagues about the good and the bad, those hospitals had significantly lower mortality rates. How could compassionate care translate to other markers? CLABSIs, CAUTIs, hospital-acquired infections. That's where we need to go. That's what we need to think about. But what we know with all of these elements is that it takes practice. Amishi Jha's work is a great way to look at mindfulness training. When that training stops, it kind of lasts for a while. People report feeling lower stress, higher attention for maybe a month, and then it disappears. We know when you're doing CPR on a patient, right, and you stop CPR, you know that perfusion rates drop to 0. When you start CPR again, you actually have to do multiple compressions to get perfusion back up to where it needs to be. It's very much similar to this work. What is that constant practice of self-reflection, attention, recognizing your connections, and building quality care? So what does this have to do with equity? What does this have to do with population health? I'm working with a postdoc at the University of Virginia right now, and we're doing a systematic review on looking at equity among self-care and contemplative practices. So people that are rolling out mindfulness practices, things like that, of the hundreds of papers that we've found, fewer than 5 even account for ethnicity or race. And only a handful, more than 5, actually account for and control for gender. Like I said, Jon Kabat-Zinn says there are a million doors into the same room. Tate Shanafelt, if you ever listen to him give a keynote, he gives a great keynote. He'll back that up and he'll say with his research, we recognize that when you see one unit, you've seen one unit. We talk about scale, we talk about efficiency. How do we build these programs to scale so we have better healthcare providers? And I would say we must take that with great warning, because self-care is unique to the individual, to the community, and to the unit. So I'd like to leave this idea that if we want to build and support more equitable practice that can spread into the communities and support better population health, we need to think about equitable care in the form of equitable self-preservation and equitable self-care. From assistants' perspective, as leaders, we need to reach out to those we're working with and first ask, what are you doing? And let's build from that so we can build our best providers. Because if we don't start there, we're never going to get to the quality we need. Thank you so much for your time. Thank you for being here and for changing healthcare.
Thank you, Dr. Cunningham, and now Dr. Melnick.